recurrence in giant cell tumors is fairly common, and this occurs mostly following curettage, but also following curettage with cauterization, curettage with cementation, and extended curettage. Most of the cases treated at this stage by excision and reconstruction do well, but repeat recurrences and metastasis to the lungs has also been reported in the literature. In these cases, we'll be showing you some of our cases. So we'll be reporting here about 8 cases of GCT in the last 20 years. And they were the GCT of the proximal femur, distal radius, distal femur, first metatarsal, middle phalanx, fibula. And all these cases were treated with repeat surgeries. And in one case of proximal fibula, the patient is continuing without any progress on abendronic acid, 150 mg orally. Most of the discussion goes around denosumab or zoldronic acid, but even abendronic acid has been doing good in this case. So just like Dr. Govind's case, this is a giant cell tumor of the distal radius. And you can see it is Campanelli gate 3. There is no tumor at all, and the whole tumor is only lying inside the capsule. So you have to go for only excision with reconstruction, and this was done with the ipsilateral proximal fibula. And in our experience, we have done 28 cases with the same side fibula, and we never repair the capsule. We do a plating, we stabilize the wrist like Dr. Govind did. We keep a plaster above elbow for 3 months and below elbow for 3 months. And by this time, there is so much of stability that these patients, even with a follow-up of now of 20 years, are doing very good. They don't have any stiffness, neither do have any pain. So coming to my topic, so this was the reconstruction. Next slide, please. So 1.5 years later, you can see the lungs are clear, but he had 2 ganglion-like small swellings on the wrist. And FNC proved them to be GCT, and they were excised. Please change. So here is the follow-up. You can see he can make a nice fist. He can do all work, and he's very much happy. Next slide, please. So this was an X-ray of a 16-year-old girl on the first side, and you can see that as she is a child, her epiphysis is preserved, growth plate is preserved, and she was treated by curettage and bone grafting. Next. And then you can see this osteolytic expansion surrounding the grafting, that is recurrence. So at this junction, this has to come out, and the proximal fibula was done. And that is the lady. This is, of course, little weakness in the AHL, and this is quite common at times because of stretching. Sometimes it is just because the muscles have lost their insertion, so it becomes weak, although not a foot drop. And this girl came at the age of 25 with 2 children. She was well married, with doing very good results. Next, please. Yet another case, a GCT of the proximal femur was treated with cementation. As you can see, the cement. So she came to us after 6 months with a pathological fracture neck of the femur, and then the whole tumor has been excised, and we have done a limb preservation system with a total hip and a constrained prosthesis. Next, please. And this is the girl. And following treatment later, she came to us at 2 years with a baby. So they are doing very good in life also, apart from having no recurrence. Next. This is the little finger, the middle phalanx. And you can see a large osteolytic lesion. And this is not the first tumor. This is after 2 surgeries. It is the 3rd recurrence. And all the people now hearing that it is the 3rd recurrence, and the scarred tissue on the finger have advised that we should go for amputation of the little finger because it will cause no much problem. but he did not want the finger to go off. Next. So that is the finger you can see, and that is the excision which has been done. And the patient was given monthly hyaluronic acid. And this is the graft from the iliac crest, and it has been reconstructed. And over time, the KY has gone out, the finger has survived, and the patient is doing good. Now it is a 3-year follow-up with us without any recurrence. Now this lady had a giant cell tumor, which was treated with curettage and cementation at some other center. And you can see here, can we go back? You can see that apart from the local recurrence, she also had soft tissue recurrence. You can find out the soft tissue recurrence only on a MRI. Having a soft tissue recurrence along with the giant cell tumor recurrence is not a contraindication to limb salvage. And so this hole has to come out. Next. And you can see it was the year 2006. So we went for a long intramedullary nail and used the fibula. It is called as Anneking's procedure. And this lady now, even in 2020, last year I got a follow-up. The bone has grown very big. She is walking without any problem. And she has now discarded her weight relieving caliper also. Next. And patella is a bone with a giant cell tumor very rarely. And due to the accessibility, the patella was excised. But you can see now here multiple cannonballs, even after excision, and the local recurrence. And she did not require any treatment and she was lost to follow-up. Next. So we had soft tissue recurrence in a case of GCT of distal radius. Another, I had shown you 2 local recurrences, one managed by hyaluronic acid, 150 mg oral tablet, and one by excision with reconstruction. And they keep on coming to us. The rest were treated with excision with reconstruction, and all are doing good without any recurrence. So this does not mean by any way that excision with reconstruction, that soft tissue involvement cannot lead back the tumor cells for a recurrence, but in our cases we did not get it. So let us discuss. Next slide, please. Well, metastasis is well known in GCT following repeat surgeries. Curettage is also known as intralesional excision, which leaves macroscopic tumor remnants, which bring about recurrence in spite of cauterization, cementation, or extended curettage. Our 7 cases with repeat surgeries did not metastasize and also did not show any local recurrence in long run. Next. This diagram I have taken from the sarcoma clinic, and you can see here that that will be the sarcoma, that will be the soft tissue with satellite lesions, and that is the skip lesion. So the cause of recurrence will be the satellites into the soft tissues. There will be the skin, which is the limiting factor, with satellites coming to the skin. And then if you have got a skip lesion, so they are the cause of recurrence. So Balke et al. Reported that involvement of soft tissue was an independent predictor of giant cell recurrence. When the soft tissue surrounding the tumor was not affected, the recurrence rate was 16%. But when the soft tissue was affected through tumor invasion, the recurrence became 30%. Next. Well, it has been suggested that the Campanacci classification may be associated with GCT recurrence, and higher the grade, higher may be the rate of recurrence. But some people feel that it is the stage of the disease, initially latent, then active, then destructive, and then aggressive. So it is when you catch the tumor, that is when you have to treat. Well, Prosser observed that recurrence of GCT was closely associated with the involvement of cortical bone. When the tumor did not break through the cortical bone, the recurrence was 7%. And when the tumor broke through the cortical bone, As in a pathological fracture, the recurrence was coming to 29%. Next. And before determining the surgical method for the treatment, the destruction of cortical bone and the involvement of soft tissue should be evaluated as a predictor for GCT recurrence. Next. Studies have shown that the recurrence of GCT is not associated with the Kempenecki grade. You should never make an apple and orange equal. They are different. So it is the surgical method which is the primary factor influencing postoperative recurrence and not the Kempenecki grade. Next. And although no relation could be established between Kempenecki grade and GCT metastasis, we still recommend excision and reconstruction for all cases of aggressive GCT and GCT presenting with recurrences. Although the lesion is coming at the second decade, early third decade, so to preserve the joint, one should work hard at this age with curettage, cauterization, extended curettage and cementation. But once there is no bone, you have to go for excision reconstruction. And same, you should avoid repeat surgeries. So we have done it in recurrences also. So what is the future? The future you can see is the KI67, the mutant P53, the P63, and overexpression of C-mypo oncogenes. CD147 is under research as a marker of recurrence, and it has been found to be an adequate marker for GCT recurrence. Now we all know that apart from how you operate, it is the genetic background of the individual which makes them susceptible or resistant to recurrence. So normal patient got the GCT, so it was because of the gene with him, and the recurrence also at times will be related to the gene CD147. And by having it done, you can have a prognosis for the patient, whether it will be recurring or not. So thank you.